All right, so we're talking about estrogen. We're talking about the mechanism of action, how it is formed initially. Where does our estrogen come from? So initially, like cholesterol can be sort of a precursor. Testosterone is going to be one of the precursor molecules. What is the enzyme that helps with that conversion? Good, aromatase is going to be a big one. Helps convert that over for sure. And then what does it do from there? What does estrogen do? Because what's our primary estrogen we're going to be seeing formed in the body? All right, estradiol, 17 beta estradiol. What does it do from there? Is it just like, we have estrogen receptors, right? So presumably we have receptors for all these different molecules here. Where do those receptors typically lie? Well, just like with other steroids and any hormone, it's going to be within the nucleus, right? So it's going to be affecting down there in the nucleus itself, changing transcription factors, all of that, right? So depending on where you're at and which tissue, you're going to find those effects can be quite different. So how it works in the bone is different than in the endometrial tissue versus in the breast tissue, et cetera. So again, basically having these different kind of subtypes of receptors is what kind of leads to those different activities. And depending on the structure of the molecule that we're having to interact there, like we talked about the SERMs, which are estrogen receptor modulators, but they're selective in terms of like which tissue they're going to be activating or maybe inhibiting, this, as the case may be, is kind of dependent on these kind of makeup of these receptors they have there. So what sort of effects would we expect to see from our estrogens? Well, certainly we see a lot of female growth and sexual maturation that happens there. Typically this is where we get a lot of the secondary sex characteristics, because usually estrogen levels surge during kind of what period of life to see this happen? Puberty, absolutely right. Also, you're going to see this is typically where you have closing of the long bones. The epiphyses will end up closing there during puberty, and so also you see a lot of like fat distribution, hair growth, etc. can be as a result of that. The endometrial effects will also be really important because you'll typically see hypertrophy of the endometrial tissue as a result of exposure to estrogen, which can lead to hyperplasia, which can lead to abnormal bleeding in a lot of cases. And if you have sort of unchecked sort of activation of this tissue in terms of hyperplasia, what could eventually happen? Yeah, you can get endometrial cancer potentially, which is going to be a risk we'll see depending on the kind of dosage forms we're going to be using, depending on the type of female patients we're going to be using this on, what their medical history is, etc. So because of that, you're going to see that we may choose one variety of agent over another based off of this factor of whether we're concerned about this endometrial cancer risk. So other metabolic effects we'll end up finding there is that certainly it can help with things like the bones for sure. It can help to decrease bone resorption, so it'll actually help to stimulate destruction of the osteoclasts. And osteoclasts normally do what? They're going to break down the bone to liberate calcium there. And so they'll also help to antagonize a little bit of the effects of parathyroid, which also stimulate this osteoclast. So ultimately we find that estrogen has a nice inhibiting or it has a nice positive effect on the bone in order to keep it around, because we know that when women are postmenopausal, they stop producing a lot of estrogen, they develop osteoporosis, right? And so then we worry about a risk of fractures. I don't know if I mentioned a family member that recently had a vertebral fracture. Did I mention that at all? All right, so this is a good example. Have a distant family member who is like probably, I think she's like in her early 60s or so, but like chronic smoker, chronic drinker, on chronic pain meds, all these different things here. Actually, it's really interesting because it kind of factors into a lot of different things all kind of compounding together. So, you think about someone who's on chronic pain meds, things like opioids, what's sort of a big chronic sort of issue there they develop? Constipation, right? So we later found out this person was, say, having a bowel movement. How often do you think she's having a bowel movement? Maybe once a week, twice a week, once every 2 to 3 weeks. She says she's having a bowel movement, right? So as you might imagine, your appetite was probably not great, right? So of course she's having a lot of like abdominal cramping, all these different things. Her appetite was not great, so she's not getting a whole lot of nutrients in. A lot of her calories are also coming in from alcohol, beer and things like that. So as you might imagine, you think her electrolyte balance was great? No, right? So her electrolyte balance is not awesome. She had osteoporosis, a lot of it, from like the smoking and being postmenopausal and all these different things there. So she was basically sitting on the couch, developed a Charlie horse, probably due to some electrolyte imbalances, tried to stand up in order to kind of work it out, and guess what happens? Fell, ends up breaking one wrist, ends up getting like, I think an L4, L5 fracture, ends up in the hospital, right? not great. So again, you can see how a lot of different medical conditions, a lot of different medications can all sort of be compounding these issues here. And now she's going to have to go for surgery, right? For a while, they thought just a back brace would have been effective, but now she's actually going to need surgery there. So you can see how these things can tend to spiral out of control there for a while. And it was interesting, she was actually calling us up because, you know, my wife's a pharmacist as well. And being in pain management, half of the work you're doing is what? Managing their bowels, right? Managing their bowel regimens. And so she was actually calling us up to say, is there anything we can get to help the, like, you know, having all this abdominal cramping, something like, you know, antispasmodic. And a lot of the antispasmodics work by which mechanism? Like hyoscyamine and, you know, bothanicol and things like this. They're anticholinergics, right? Because by blocking the parasympathetic activation there, you're going to find that will help to deal with some of that cramping. However, what would an anticholinergic do to this patient's bowels? Slow them down even more, right? So again, initially they may be complaining, oh, I got this like abdominal cramping and stomach pain and all these things, and I just want something to help with that, when ultimately it was because of the other medications she had that was the issue. So what do we do for her? Well, we recommended other more standard bowel regimen stuff. Now listen, you're going to need some enemas, you're going to need some stimulant laxatives. We need to get this thing moving, and just sit on the toilet, get a good book, get your Kindle, and just wait for it to come out, right? And guess what happens when she had a decent bowel movement? All the stomach pain went away. She felt so much better. Like, she wasn't like dizzy all the time. Like, so again, if I teach you anything out of this class, the first thing being to just look stuff up. The second would be never underestimate the value of a good poop. Okay. Anyways, enough of that tangent. Was somewhat relatable, but anyway, so estrogen is good for the bones, is what the whole thing was trying to get back to. We'll also see that due to liver effects, this can have some issues with cholesterol and things like that. So you will see things like increases in HDL as a result of that, but you may also find things like triglycerides might be a little bit higher, so kind of varying metabolic effects as a result of the estrogen. Other factors that are important here include the coagulation effect. So as we've kind of alluded to before, having excess estrogen around, you'll find that actually help to upregulate production of things like your clotting factors, so things like 2, 7, 9, and 10, which should look familiar to you if you recall that these are the sort of the vitamin K dependent clotting factors that, you know, things like warfarin effect. It'll also do things like decreasing antithrombin 3. So again, one of the big risks you'll find with estrogen supplementation is going to be what? Risk for clots, right? So again, it's that classic presentation of a young lady who's on oral contraceptives and maybe she's a smoker and comes in with chest pain, right? Like, always got to suspect it's going to be, you know, something like a PE as a result of that. Other things like, you know, mood, libido can be affected here. You'll also find that because we can have a little bit of bleed over effects in terms of which receptors these different hormones are going to be affecting, you'll find that you can have things like edema and fluid retention. Why do you think that would be? Well, because if you imagine that it hits some of those mineralocorticoid receptors, right, things that aldosterone would normally interact with, what does aldosterone normally do? Cause fluid retention, sodium and fluid retention, which is why you may find that a lot of patients, especially around their period, they complain about things like bloating, edema, things like that, as a result of the fact that they're having a little bit of this extra mineralocorticoid effect. Some of that's related to estrogen, more of it's probably related to the progesterone activity, but we'll see that especially when we're supplementing this, that could be another thing to worry about. So you may think about things like a patient with CHF and you want to supplement with some estrogen, that could have a negative effect in terms of their fluid balance. So when are we going to use our estrogens? This is some different clinical settings you might use it. It include things like primary hypogonadism, where basically you had a patient with a deficiency for whatever reason. So for instance, if maybe they had a pituitary tumor that had to be taken out and they're not producing their own LH and FSH anymore, we can maybe supplement that and give their own estrogen. You'll typically find that in a lot of cases, when we're applying estrogen to these patients, we may try to use different dosage forms that will mimic a typical cycle in terms of where estrogen levels might be low or higher. And so you'll see that especially with like things like birth control and different hormonal replacement therapies, that you'll see that basically we'll try to give them maybe active hormones, say for 3 weeks, and we may vary up that dose during that 3 weeks there, and then we'll have a withdrawal period, right? So that last week we'll kind of simulate what normally happens during the end phase of the sort of the menstrual cycle there. As you see here, we'll typically start it up around 11 to 13, typically when these patients are developing puberty anyway, and then it should have sort of normal sexual maturation for those patients there. And then you can add on progesterone. We'll find that progestin is also really important to sort of help out with that that hyperplasia, especially of the endometrial tissue, that you get from estrogen. So you kind of think about Estrogen and progestin kind of being sort of antagonistic to one another in that regard. Progestin typically inhibits some of the hyperplasia of that uterine tissue. We'll also use this for postmenopausal hormonal therapy. So this can be, we call it HRT, or hormonal replacement therapy. We can use this for. Typically, you'll be using this more as like symptomatic management for these patients here. So if they're complaining of things like, vasomotor symptoms, how does that normally manifest? The hot flashes, or as my mom positively coined the term, power surges. I was like, that's a nice way to look at that. But, they can develop other things like genital atrophy. They can develop dyspareunia. Anyone know what that means? Yes. Yeah, pain on sex, because again, they're having a lot of vaginal dryness and vaginal atrophy. So, and again, there's going to be different ways we can manage that, either with systemic therapy, or we can try to look for more locally applied medications, and we'll see what are some of the benefits of doing that in just a little bit. Also find that as those estrogen levels are dropping, we know that they're going to accelerate bone loss, and so that's one thing we're certainly worried about, is the vertebral hip and the wrist fractures, which again, 2 of which that family member actually ended up suffering as a result of that fall there. And then due to changes in their lipid panels, you can see here that can accelerate atherosclerosis. So in addition to all the other metabolic stuff going on as people age, this is another thing we'd be concerned about there. Typically, you're going to find that we're not going to administer estrogens as a form of cardioprotection. There's actually a big study called the Women's Health Initiative that actually ended up showing no benefit. And also, there may be some risk as a result of the kind of procoagulant effects there, that it may actually decrease or actually increase the risk of cardiovascular mortality. So not only that, but you also worry about things like, breast cancer risk and whatnot. So we'll talk a little bit more about that later on. So, typically, when you're kind of trying to consider those patients are going to be good candidates for hormonal replacement therapy, you have to consider sort of the cardiovascular risk, their osteoporosis status, breast cancer, all these different things here, sort of what their risk factors are, what their family history is, et cetera, to determine that. Typically, we're going to find that transdermal or directly administered vaginal estrogens tend to have the lowest risk, mainly because, for one, with the vaginally applied medications, it's just local, so you're not really getting a whole lot of systemic effects. So again, it's just good for symptomatic management, just in the local area. Why do you think transdermal would be beneficial? It's long lasting, yeah, so you don't have to change it as often, so it helps with compliance. What organ might it bypass? The liver, right? So just like we talked about, how do a lot of the testosterone products, how are they administered? Yeah, typically transdermally or they're injected, but here we can find that transdermal will skip the liver in a lot of cases and will help to sort of mitigate some of those risks there. So that's why you may see either like estrogen creams, transdermal creams, you may find patches, you may find different ones there. We'll kind of look at in a little bit. Typically, you want to go with the lowest dose that's going to be effective for these patients, just to manage whatever symptoms are really sort of problematic to them. And one sort of caveat here is that if a patient has had a hysterectomy, and you're not really worried about the endometrial cancer risk, then you can give an estrogen by itself, and that's no problem. If they still have an intact uterus, you want to make sure that they are also going to be getting a progestin along with that, because you'll find those are going to be helpful to prevent that kind of over hyperplastic effect of the estrogen. So one thing to kind of note there. So other things we can do, obviously, if they are at risk for osteoporosis because they're postmenopausal, what else do you want to also make sure they're getting a lot of good amounts? Calcium, vitamin D, but also think about their other organ function, right? What organs need to be functional to actually use vitamin D? Kidneys and the liver, right? So you got to have both of them to actually get that fully activated form of vitamin D. So you want to consider that. So again, then Caucasian smokers or inactive, low calcium intake. Guess what that family member was? All those things right there, and guess what? She had those fractures. So again, very typical, common things are common as it turns out, right? And we're looking for things like, just for atrophic vaginitis, like topical products are going to be best used there. When I say topical, basically mean like intravaginal products are going to be best suited for that, because again, they're going to lack a lot of the systemic side effects we'll see. In some cases, we may use estrogens as a form of ovulation suppression. Why do you think that that would be useful? So patient dysmenorrhea. But think about it, what does estrogen do to that HPA axis? Well, if you recall, remember that we have the hypothalamus is releasing what? GnRH, gonadotropin releasing hormone, right? And so then that stimulates the anterior pituitary to release what? LH and FSH, and that's what's directly stimulating that tissue there to produce things like estrogen, stimulate the ovaries and whatnot. And so if you have this intractable dysmenorrhea, we can actually administer exogenous estrogens, and that will help to shut that down. So basically it'll help to inhibit both the hypothalamus and the anterior pituitary to stop releasing those hormones, and such that it should help to decrease estrogen production, help to decrease that bleeding. And we'll do this occasionally. We'll have patients who will come into the ER, they're having this, really heavy bleeding, it's just not stopping. Maybe they're getting a little dizzy, a little pale, and then we'll actually administer things like estrogen either orally, or we may actually do it intravenously to help stop that bleeding there, because it's basically going to shut that whole thing down. And again, that's kind of the process that we're going to be using this for oral contraceptives, is again using maybe lower doses to help shut down the ovulation cycle there. And so we may also end up finding using exogenous estrogens can also help with things like excessive androgen secretion. Why do you think that would help? Remember, what gets turned into estradiol? Testosterone, right? So these patients are in a state where they're producing a lot of that testosterone, but maybe not a lot of it's getting converted over to the estrogen. By supplying exogenous estrogen, you also have a shutdown of the HPA axis such that they are not going to be producing as many of those androgens anymore. So if you had someone who's sort of in a hyperandrogenic state, not adrenergic, but androgenic, right? So they're having that hirsutism, things like that, those kind of masculinizing sort of features. You can help out with that by giving exogenous estrogens, right, as a means of shutting down production of those androgens. So again, just keep those negative feedback loops in mind in terms of how this is going to be working, right? So that's going to be the biggest key there.
So you're saying it's like you'll get the one that the hormone that you want, but you're going to get the downregulation of the pre-stream.
Yeah, essentially, yeah. So again, if they're in a state where the balance is such that they're having more androgens than estrogens, well, I can supply them extra estrogens, and by doing that, it's going to shut down production of those androgens in the first place, essentially. Adverse effects of estrogens, and they are numerous, and it's important to kind of go through them because you want to be educating your patients on these. Some of these are going to be things that they may not need to stop therapy immediately. Some of them are going to be much more worrisome, which you probably already have some idea of what those are. Again, if you have a patient who has any sort of like unknown cause for vaginal bleeding, that is certainly something you want to have checked out prior to starting any sort of estrogen therapy, because you obviously want to make sure they don't have any kind of cancerous growths that are there that you may be exacerbating by applying estrogen to these patients there. That's one of the big things to note. Be aware that these can cause abnormal bleeding. Sometimes it's one of those things there where it's like, well, these can actually help patients with abnormal bleeding and also can cause abnormal bleeding in and of themselves. So you're going to find that depending on the dose and depending on the type of estrogen they're getting, that it can be pretty variable depending on the patient there in terms of what they're going to respond really well to, which is probably why you're going to see such a variety. I'll show you some charts in just a little bit of all the various varieties of hormonal products that are available. And the goal is not to understand or to memorize every single one of them, but to kind of understand how they're using the medications and how they're sort of combining them, how they're doing the dosing of them to sort of, try to either mimic the cycle or not. And we'll see there's ways to help them try to mitigate these side effects if possible. So there's a lot of varieties because everyone kind of responds a little differently. Best thing we can do though is to make sure we're giving as small estrogen dose as possible just to manage whatever symptoms that they're having there is going to be beneficial. And then we'll also tend to find that we can try to schedule out the bleeding periods similar to what a normal menstrual cycle would be. And so you may find that a lot of the estrogen products may be given sort of cyclically, where they'll get active estrogen, say days 1 through 21, and then they'll have, say, either placebo pills or just nothing for that last week there. And that will allow for that withdrawal bleeding to occur once estrogen levels sort of drop down. The body senses, okay, we don't need this endometrial tissue anymore, and then just can slough it all off, right? We'll find that again, if they have an intact uterus, we're going to give it a progestin along with this, and it'll help to prevent sort of that that hyperplasia that occurs there. And we'll go more into the progestins in just a little bit. So certainly cancer risk is going to be a concern with this one, especially for patients that have maybe like a high risk history of estrogen sensitive breast cancers. In their family tree, we can find that whereas progestins help to decrease the risk of endometrial cancer when given with an estrogen, it does not confer the same benefit for breast cancer risk. And so that is why we end up using things like SERMs, which we'll get more to a little bit later on in terms of finding drugs that may act at agonists at the estrogen receptor, say on the bone, but maybe as an antagonist on the breast tissue. And that way it's going to be able to help balance that out such that the risk is not going to be as high for those patients, especially if they have that family history. As I mentioned, endometrial carcinoma is a risk, but we give progestins along with that if they still have an intact uterus. And then interesting, there's one product they were able to give women called diethylstilbestrol. This was back in the day. And it's interesting because they actually found that it was when the moms were treated, it was actually the daughters that were actually developing this cancer, say like 10, 20, 30 years down the road. And so it's one of those really kind of interesting epidemiologic sort of investigations to find out what was causing that. So actually it's just not administered anymore there. Other kind of normal things you're going to find include things like nausea, vomiting. Why do you think you get breast tenderness? What does estrogen do to the breast tissue? Causes hyperplasia, stimulates it, right? So again, if that tissue is starting to swell, that can cause a little bit of tenderness associated with that. You can find things like hyperpigmentation, where actually can stimulate melanin production in the skin cells. Migraines are kind of interesting because if you recall back when we talked about migraines, what is something we could use to help manage migraines in these female patients? You can give estrogen. So again, it's one of those things where sometimes it can help, sometimes it can hurt, and it depends on the product there. So you want to be cautious with that. Cholestasis is going to be more likely to occur with which dosage form, you think? The oral ones for sure, right? Because again, those are the ones that are going to be most processed to the liver, especially when they're first taken in. Hypertension can occur. Why do you think that? Yeah, those mineralocorticoid effects, some of that salt and water retention that can occur there. So that was another thing you want to watch for. And again, these can be mitigated by trying to use the lowest dose possible. So in terms of contraindications to administering estrogen, this includes things like estrogen-dependent neoplasms. Obviously, that makes pretty good sense. You don't want to exacerbate those at all. Undiagnosed genital bleeding for sure, because you want to make sure to rule out any scary stuff that could kill the patient that could be exacerbated by the estrogen, so make sure to rule that out. Liver disease, obviously this could exacerbate that. Probably you're not going to see this to be the same extent as you would find for, say, like the oral androgen products, but it can still lead to some hepatotoxicity, so you do want to watch for that. Thromboembolic disorders and heavy smokers, because they're at risk for clots, right? So again, those are the big risks. And again, pretty good education points for all your patients to not smoke, but especially if they're going to be on estrogen products, that definitely compounds the risk there somewhat significantly. Okay, so then switching over and getting into the progestins. So again, it's kind of the other part of the cycle there we're going to see in terms of we have the estrogens, then we'll have progestins that will kind of surge. When do normally progestin levels sort of bump up during the cycle? Normally towards like the second half of the cycle there, especially after ovulation, you'll find. You can go back to those charts there and see where those are peaking up. Again, you're going to find progesterone is sort of the main one that we produce as humans. You're going to find a lot more variety in terms of the products that we're going to use. So we can supplement just straight progesterone, but we have a lot of different varieties that we'll look at, and the side effect profile can change depending on which one we're using there. But we do know it works as a precursor to estrogens, androgens, and a lot of adrenocortical steroids. And so because of that, you're going to see a lot of cross activity at those receptors there. So you're going to find some that maybe are agonists at the androgen receptors, and some that are maybe agonists or antagonists at the mineralocorticoid receptors. And so because of that, there's a lot of variety. And typically when you're switching around, say for instance with like oral contraceptives, you're switching based on the progesterone content, or which specific progesterone that is present there. And so you also find these are produced in the ovaries, the testes, and the adrenal cortex in of itself. So again, it kind of makes sense why you get a lot of bleed over effects in terms of different activities at different receptor types. As I mentioned, the synthetic ones that we have, we're going to have a lot of variability there. So depending on which one we pick, you can find different effects on things like fluid retention. You can find different effects on things like androgenic effects you can find for these patients here. So we'll look at that and kind of find a good balance between all of that. So looking at this, as I mentioned, the historical problem is that bleed over effect. And so if I say AR here, that just stands for androgen receptor, whereas with MR, that means mineralocorticoid receptor. Right, so if it stimulates that MR, it means it's going to cause more fluid retention. If it stimulates the androgen receptor, obviously we get more of those masculinizing sort of effects there. So here are some common ones you're going to run into pretty frequently in terms of progestins are going to be included with your estrogen-based products, or you may find them alone in some cases there. So things like norgestrel, levonorgestrel, norethindrone, norgestimate, desogestrel, and then drospirenone. Drospirenone probably being the newest one out of the group here. And so basically looking at this, you can find things like norgestrone and levonorgestrel have pretty high androgenic receptor activity, which may not be great, especially if they're developing things like hirsutism and things like that, right? So again, based on the side effect profile, what your patients experience, they may not have a whole lot of issues with this and can be on it no problem. And in fact, a lot of like your kind of bread and butter sort of oral contraceptives include things like levonorgestrel. For some patients, though, it's going to be a deal breaker and they don't want to take it anymore because of that. And so you maybe want to switch them over to something that has less of that receptor activity, right? So maybe something like norgestimate that has low androgenic receptor activity, maybe has a little bit of estrogen receptor activity. Clinically doesn't really matter that much there because you're combining with an estrogen typically. Ideally though, you're going to find, and this is why a lot of people like drospirenone, because it actually has anti-mineralocorticoid receptor effects. So what do you think that does? You can lose a little bit of fluid, so you see less edema with this, less weight gain associated with this particular progesterone, and anti-androgen receptor activity. So you don't have things like that hirsutism and maybe the voice deepening and things like that that can come about from androgen receptor activation. So you're starting to see a lot of products being used with drospirenone, but certainly you can still find any of these available. And I'll show you some charts here in just a little bit that give you some ideas what that looks like. So in terms of the kinetics here, we're going to find that we don't have nearly the same sort of hepatic effects as you're going to see with the estrogens here, and they're not going to have the same sort of side effect profile because of that. So no risk for clotting specifically with progesterones like you would see with the estrogens there. Again, they get pretty rapidly excreted in the urine, so we don't have to really worry about it so much from that standpoint, which is beneficial. And so their mechanism is going to work similar to how our androgens and our estrogens work. Down in the nucleus, they find their particular progesterone receptors and they cause changes in transcription, either in starting it, stopping it, whatever the changes are going to be, but that's going to be dependent on the tissue there, right? So what sort of effects can we expect to see as a result of progestins being released? We can see things like increased basal insulin levels and maybe insulin response to glucose. That can be sometimes beneficial. Sometimes you'll have these patients that may have sort of different endocrine issues that may be leading to some insulin resistance. This may be helpful for them, may help with some of that insulin resistance there and helping to get bigger insulin levels. That can be useful. As I mentioned, this may compete with aldosterone in the kidney, and so by competing for that, the body then responds by releasing even more aldosterone, which again can lead to some more of those sort of fluid retaining sort of effects there, sodium and fluid retention there. You'll find maturation and secretory changes in the endometrium. So this is sort of where the estrogens are going to kind of stimulate the endometrial tissue to kind of grow sort of unabated. And I kind of think about it like estrogen sort of being the fertilizer for the endometrium, kind of causing, if you kind of think about the endometrial tissue as a lawn, okay, stick with me here for a second. Think about the uterus as a nice lawn, your backyard, and you give it a bunch of fertilizer like estrogen, right? Does the grass all grow at the same exact rate? No, it's like you're gonna have some areas where it's a little bit higher, a little bit lower there. Progesterone is kind of nice because it helps with the maturation and sort of applies like a nice lawnmower effect and kind of just makes everything nice and uniform and ready for pregnancy, right? Again, I barely understand how women work, but this is how my mind helps to keep it all straight. So. Regardless there, which is why you end up seeing that the estrogen levels will kind of surge early on during the menstrual cycle, but then progesterone sort of peaks up, especially after the ovulation phase there. Because again, we're getting things ready for that implantation to actually occur. Anyway, so looking at that, you'll find those secretory changes, maturation changes that occur there. And then looking at our synthetic agents here, we're going to find that ideally they have less androgenic effects. We're going to find that may not be the case with all of them, as we already saw. We'll see some of the anabolic activity, and hopefully that's going to help to reduce some of the side effects of natural progesterone being secreted. So how do we use these? We're going to either use them in combination with estrogen for hormonal replacement therapy for patients that maybe still have an intact uterus. So that can be one thing we're using it for. We can also use it for ovarian suppression there. And so again, this is something that we'll find either being used for things like contraception, or if we just need to, if they're having things like, dysmenorrhea or normal bleeding, things like that, this can also be useful here. You can use just progesterones by themselves to shut down ovulation. You're going to find, though, that it may not be as effective as if you're using both estrogen and progesterone, because if you recall back to that negative feedback loop, progesterone will additionally go back and inhibit things like GnRH and LH and FSH release from the hypothalamus and the pituitary. And there's some different dosage forms we can actually use here. So a good example of this would be medroxyprogesterone acetate or Depo-Provera. So has anyone ever heard of like a Depo shot? I don't know, I've mentioned it before, but I'm sure people have heard about like getting their Depo shot. This is basically a form of ovarian suppression, or you can use it as birth control essentially, where basically it's an IM shot that's given. Basically it's sort of an insoluble form that will sit in the muscle and slowly release into the bloodstream. And the benefit there though is it lasts for 90 days, right? So who might that be beneficial for? Maybe non-compliant patients, like maybe you have patients with like maybe some mental health disorders, maybe they have those high-risk activities. So think about patients with like bipolar disorder or maybe like schizophrenia that may be at risk. This may be a good option for them because it helps them to stay compliant with that and make sure they don't get pregnant potentially. We're gonna find there's some issues with that because again, do you think the drug just works for 90 days and then all of a sudden it turns off? Nah, it's gonna be a big issue with that as well. So we'll see some ways we can get around that a little bit later on. Not ways to get around it, but some considerations to make about that. But you will find kind of prolonged anovulation amenorrhea as a result of that because you may have these lingering levels. And so for instance, if someone's maybe trying to schedule out their pregnancies or something, this may not be a good option there because of the fact that they may have a prolonged period before they go back to ovulation. We'll get more into details on that when we talk about the OCPs in a little bit. But you'll see it used for things like bleeding disorders, endometriosis. These are good for patients who maybe estrogens are going to be contraindicated, maybe due to like breast cancer risk or something. You can use progestins by themselves, and so that can maybe another use for these products here. As I mentioned, though, you're going to have a longer time to return to normal ovulation. You'll find that typically with like, say, a normal sort of estrogen progesterone based birth control, that patients will return to ovulation pretty soon after they stop taking it, whereas with the progestin only products, they may have more of a prolonged period of time, so it may be more difficult for them to get pregnant depending on what their schedule is, right, what they want to do. In terms of adverse effects, we may see things like increases in blood pressure due to things like the mineralocorticoid effects there. You may find things like the androgenic effects tend to have a negative effect on the lipid profile, so you may find like drops in HDL, things like that, so things you'd want to monitor for. So, now we can talk more specifically about how we're using these products for things like hormone replacement therapy. I think I'm going to give you a 10-minute break now, and then we'll come back and then keep hitting this. All right, so there's one question here. I heard ibuprofen can help decrease spotting. Is this true, and what is the mechanism of action? So I posit it to you. What do you think? Pose it to you. What is the mechanism there? We've already talked about this before. So what stimulates uterine contraction? Prostaglandins stimulate uterine contractions, right? Remember we talked about dinoprostone and misoprostol can stimulate uterine contractions. So what would ibuprofen do? Inhibit prostaglandin synthesis and can inhibit some of that contraction of the uterus. And that uterus contracting is what's causing that sloughing of the material. So potentially it could be useful to help with some of that bleeding there. Also, it's got an indication for dysmenorrhea specifically, so it can help out with some of that cramping and whatnot. As an analgesic, as a prostaglandin inhibitor, it also helps out with that aspect of it as well. So kind of multiple things there. Now, would I use that specifically to stop uterine bleeding? Probably not, but it may not be a bad idea as an add-on agent. And frequently what you'll find for a lot of like over-the-counter products for like menstrual cramping and menstrual related pains is frequently it's going to be a combination of usually an NSAID, like ibuprofen or aspirin. You find some acetaminophen in there, get some additional analgesic effects, and they frequently put caffeine in those products. So if you look at a Midol, for instance, there's caffeine. And what do you think caffeine does? It's kind of a mild diuretic, so it actually helps out with some of the fluid retention and whatnot that you'll see with that. So it kind of can be some additional benefit there, right? So just something to consider. So that's kind of the mechanism there. You can kind of think about it for that. Again, I would not use that as sole therapy, but it may be beneficial. And there's actually some cases too where it actually can delay a period from occurring because you're inhibiting that cramping there, but it's going to be kind of variable between women in terms of how that's going to affect them. But also remember we talked about ibuprofen being a category D pregnancy category once you got into the third trimester, and part of it was related to that PDA or that ductus arteriosus closing prematurely. The other part of it could delay labor, and that makes sense based off what we know about the blocking the prostaglandins, inhibiting that tocolytic sort of effects there of the prostaglandins, right? Hopefully that makes sense. All right, so getting into talking about hormone replacement therapy. So what are our actual like approved indications here? Basically, we're going to be treating sort of these mild to moderate or moderate severe vasomotor symptoms. They're associated with that drop off in estrogen progestins associated with menopause there. We can treat things like vaginal atrophy, vulvar atrophy that occurs here that leads to a lot of being quite uncomfortable for female patients. You're going to find a lot of dryness, dyspareunia, etc. And so by utilizing things like hormone replacements, especially if you're using like intravaginal products, it can directly help to stimulate that tissue to help out with a lot of those effects there. It's going to be much more comfortable for them. And then also other indications to help out with that postmenopausal osteoporosis by helping to supplement what they lost due to their ovarian function going down, such that they can have that inhibitory effect on the osteoclast. So typically what you're going to find is we can either use estrogen progesterone therapy together. We can use estrogen therapy alone, depending on the case there. But typically for postmenopausal women, you typically want some sort of estrogen being involved here for the most part. By combining the progestin in, this is going to be better for patients to still have an intact uterus because of the fact it's going to help to prevent a lot of that endometrial hyperplasia from occurring there. And so you can find that because these patients, they don't necessarily need to have any sort of withdrawal bleeding. So you can actually give them estrogen progestin every single day. You don't have to have any kind of withdrawal effect, but some people still like to have that sort of normal cycle there. And so you may find that some products may actually give, say, estrogen, say, on day 1 through 25, and then they'll add in, say, progesterone on, say, days 10 to 14, and then maybe they'll be drug-free, have a drug-free period from day 26 to 30, for instance, right? Some of that is being done to try to help mimic sort of what that normal cycle would have been for that patient before they went into menopause, right? So as I mentioned, with estrogen therapy by itself, it's going to be better for patients that don't have an intact uterus, and you can either see it being used continuously or sort of cyclic therapy for them. Again, some people feel like it's more natural to have that sort of withdrawal period, so people may prefer that, but there's no absolute medical necessity to do so. So you can receive continuous estrogen, and that's no problem for those patients there. Now remember that as compared to, say, oral contraception or for prophylaxis of ovulation, trying to prevent that from occurring, how do you think the levels of estrogens differ between the two? So you have HRT and you have ovulation prevention with, say, like our oral contraceptives. How would you compare the estrogen dose? Which one do you think is higher? This one? So remember, if you kind of think about it, like with this, we're just replacing what they're missing, right? So we're just trying to give them physiologic doses of estrogen and progesterone potentially. With things like oral contraceptives, we're trying to shut that whole system down, right? We don't want that pregnancy to occur. We don't want ovulation to happen. So we're giving super therapeutic doses to make sure that negative feedback loop is completely shut down. So typically you can find that those doses will be much higher, and that may be related to some of the side effects you'll see with things like oral contraceptives. Now don't get fooled by the dosing. Depending on the estrogen product that you're looking at, their potency may be quite different. So you may find that some of the estrogens used for oral contraceptives are only dosed in, say, micrograms. That does not mean that they're not very powerful and very potent, and they're still causing severe suppression of that system there. So here, when I mentioned with HRT, you could do low-dose oral contraceptives, but just keep in mind that if you were to give them, say, full dose, that's probably not going to be necessary, because again, we're just replacing what they're missing. So in terms of dosage forms, we have many that are available. Certainly oral is going to be the one that has the most first pass effects and is going to have the most effects with the liver. And so again, you can see things like that cholestasis, you can see things like the clotting factor production and whatnot with the oral dosage forms most predominantly. It still happens with the other ones, just not as strongly. Transdermal tends to be more preferred in patients, say, for instance, if they have a history of hypertension, maybe if they have risk for VTE, cholelithiasis, things like that. Those are patients that are going to be better served by a transdermal product. Still get systemic effects happening, but it's not going to have as big of an effect on the liver there, okay? And then intravaginal is going to be preferred if they're only having vaginal symptoms, so maybe they're not really having the hot flashes so much, but maybe they're having that dyspareunia, the vaginal dryness, itching. This can be beneficial for them. You'll still get some absorption, but it's not going to be nearly as significant as you would see with either transdermal or oral in those cases there. And even some things that help to mitigate that even further, because some of these are going to be creams and ointments that you can administer directly intravaginally. Usually there's an applicator associated with that, which I'll show you a little bit in just a few moments here. But there are also other dosage forms that may help to mitigate further absorption, things like tablets or even like rings that have been, not to use the, no pun intended, but impregnated with drug, that will actually help to release that slowly, and you get very little systemic absorption there, right? So, don't memorize these slides specifically, but it's the concepts I want you to get here in terms of how these different products may be used and presented. And again, if you work in OB-GYN or if you're going to be prescribing these medications here, you'll sort of get familiar with your little sort of your staple sort of drugs, right? Typically, for providers who've been working, say, in a given field, do you think they remember every single drug that they learned about in pharmacology? No, but on your boards, could you be tested on any drug we learned about here? Most likely, right? So you typically find you'll kind of shed away a lot of these things, but you'll have your own little stable of drugs that you use when you're working. And so again, it's just important to know a lot more of the concepts behind these things and individually memorizing specific products. But just to give you some ideas of different dosage forms we have here, certainly we have different estrogen products themselves. So like we mentioned, the conjugated estrogens, that's typically your Premarin product. Remember where Premarin came from? From horse pee, right? Pregnant mare urine had a lot of conjugated estrogens there that we could use, things like equilinin and equilin. Again, notice the dosing here. Don't get fooled by that. These are milligrams per day that they're receiving. Don't get that confused with the oral contraceptives in terms of how strong these are. These are going to be just replacement doses. These are not going to be for actual ovarian suppression, like we'll see in a little bit later on. And again, you can find here that they have wildly different dosage that you can administer. Again, what's the best dose for these patients? The smallest amount that we can give to manage their symptoms, right? So again, if you can get their symptoms under control and maybe you try to titrate it down if you can, that's going to be beneficial for them overall because you limit some of those more systemic sort of effects there, right? And again, these are just the various types of oral estrogen products you may run into. Here's some other dosage forms, things like patches that can be administered. So for instance, these may be given, say, twice a week, just once a week. Obviously that helps out with compliance and also helps to mitigate a lot of the liver effects you're going to find by giving it transdermally here. And again, you're going to see there's a gazillion different brand names associated with these, but again, still 17-beta estradiol. So what we naturally produce in our cells is just a synthetically formed version of that. Also some transdermal gels or sprays that can also be used as well. Again, a lot of different varieties out there. You'll find out what their patient's insurance will cover, you'll figure out what's available, and be able to, pick the right one for your particular patient there. Here's some examples of vaginal estrogen-based products here that can just be directly applied into the vagina, and that way they just work very locally. You're not going to have a ton of really systemic effects you're going to see there. So for instance, you may find that they will start off, say, like a higher dose, for instance. So for instance, this one here is Estrace vaginal cream. Maybe you do 2 to 4 grams per day. And again, even though we're giving grams of the product there, very little of it's being absorbed systemically. So again, don't get too confused by the dosing there. You may do this for 1 to 2 weeks, and then maybe you'll back it down for more maintenance of symptoms there. So you try to get the symptoms under control, especially if they're having a lot of that vaginal dryness and itching and whatnot, and then back it down to get the lowest effective dose you can, right? So those are the big ones to see. And you'll find that these can still be used sort of cyclically. So for instance here, you can find one where they're using active drugs for 21 days and then they'd be off for 7 days. And what do you think is the risk for telling a patient, take this for 21 days and then not take it for 7 days? You'll lose count of the days. I mean, like, I live by my calendar. If I didn't have my Google Calendar, I would be completely lost. I probably wouldn't have shown up at all this morning. So again, to have a patient be like, all right, take this for 21 days, off for 7, like they can get confused unless they have a really good record keeping, or some of them are just really that good at keeping track of that kind of stuff. But again, the idea is to allow for some rest for the vaginal tissue to not be constantly exposed to that estrogen. Again, it's not medically necessary, but some people feel it's more of sort of a natural cycle and they prefer that sort of thing. So a lot of it comes down to what your patients really prefer, right? There are also some rings you can administer as well. Again, these are usually some kind of like rubber or plastic that has the drug sort of impregnated into it and then will slowly release over time. So for instance, here's an E-string that can be given and basically it'll release about 7.5 micrograms per day of the drug for 90 days. So again, the whole dose for the whole ring itself is 2 milligrams, but it slowly leaches that out for 90 days. So again, from a compliance standpoint, it's nice. What do you think happens if it falls out? Just pop it right back in. So again, it's not like you're going to completely lose the product there. So that's one thing you can always educate your patients on. Hey, if it falls out, just put it back in and the drug is still there. It's still going to be just as effective, right? So again, just different dosage forms you have available to your patients. So here's some examples of what these things look like. So for instance, with like the Premarin, notice here there's going to be an applicator that you'd actually fill up with the ointment itself. What's going to be an important counseling point for these patients? Wash your hands, wash your devices, your stuff, like keep it clean because again, you don't want this to be a source for infection potentially. So make sure they're going to be cleaning all these things here effectively. I don't want to, and again, should they be sharing products? The nurse, no, that sounds silly, but sometimes the obvious things need to be stated to patients. So little things to consider there, right? So you never know in these, like, if you go to like the villages, like in the nursing homes and stuff, like you never know what those guys are doing out there. You never know. Anyway, here's an example of like what an E-string would look like. Again, this can be applied directly up next to the cervix and can slowly release that drug and again provide local concentrations without getting a lot of systemic sort of effects. So here are some examples of what it would look like if you were to combine estrogens plus progestins for these patients here. So again, just to give you an example of what these look like, different products can be mixed together. So here you'd have like conjugated estrogens, like a Premarin, plus your medroxyprogesterone. This is a pretty common one you're going to run into. And so here you can find either continuous cyclic drugs or continuous combined ones, as we'll see in a little bit. So for instance, here when you say E, that obviously references the estrogen, P's referencing the progesterone. Here you'd find that, okay, you would be giving, say for instance, 2 tablets. They'll be there. You'd be taking ones that just contain estrogen by themselves for the first 2 weeks, and then for the last week there, you'd end up taking an estrogen plus progesterone tablet. And then some of these may just have no pills available for that last week. Some of them will have placebo pills that are there, and the benefit of placebo pills is what? Keeps you on track. Make sure you're taking something every single day, so at least they physically are doing the act, and that way they will be more likely to stay compliant for that kind of stuff there. So that's an example of sort of a cyclic form to try to, again, mimic what the normal cycle would look like for those patients. First is if I just did, say, a continuous combined one, you'd be just, say, using one that combines these two together. You just take the same pill every single day, and that way you're getting equal levels of both estrogen and the progesterone. Again, no benefit of one versus the other. You just have to see how your patients are responding to it and see what's going to help control their symptoms in particular. And again, who's going to need that combination of estrogen plus progesterone? They still have that intact uterus, right? Because again, you don't want that endometrial tissue. If you're just using estrogen by itself, imagine that lawn just getting way too much fertilizer and everything just growing way too much. Eventually, you know, you're going to have like, I don't know what the equivalent of cancer for a lawn is, but imagine, you know, like toddlers getting lost out in the middle of the, you know, grass or something like that. I've seen that happen with my own children, so not great, right? Regardless, so this is when you're going to use that combination together there, right? So again, just different dosage forms that are available. And again, depending on how they respond to the progesterone, you may pick a different one based off of their symptomatology. So again, if they don't really respond well to the medroxyprogesterone, maybe for instance, they get too much fluid retention, or they get maybe some of that hirsutism, switching over to something like drospirenone may be able to help out with that. So again, switching the progesterone out can be useful for mitigating some of those side effects. Here's ones that are going to be, for instance, an oral intermittent combined, where say for instance you're doing estrogen alone for 3 days and you follow it up with the combination for 3 days. Again, not one benefit to one or the other, but you kind of understand why you may see these different types of products and what they're actually doing when you see these different tablets and dosage strengths and all that kind of thing. There are transdermal products as well that combine the two, and again, that can be beneficial to mitigate some of those liver effects. And then potentially if you're just using progesterones by itself, you may find these as either, say for instance, like injectable formulations that will last long durations of time. You may be giving oral products, so just progesterones by themselves. These are better for patients that are at risk for side effects from the estrogens, right? So high VTE risk, high risk for breast cancer, and things like that. These are going to be useful for those types of patients, right? However, you're not going to find the progesterones are going to be as good for the bones as using an estrogen itself, right? So you also want to consider the osteoporosis risk for those patients. So other things that we could do to help maybe manage some of the symptomatology for postmenopausal women include things like antidepressants can be somewhat useful. And again, you'll find that loss of those hormones can also affect their mood quite significantly as well. It may exacerbate things like anxiety or depression. So you may find that you need to be on one of these medications anyway, and so you get sort of a side benefit of help with things like the vasomotor symptoms here. So SSRIs, SNRIs like venlafaxine, all these can be useful to help manage those hot flashes. Maybe it helps kind of regulate things like serotonin and norepinephrine that may be sort of dysregulated for those patients having those vasomotor symptoms. Other things that have helped as well, things like anticonvulsants like gabapentin have been used, clonidine. So a lot of different options that are out there can be used in combination or by themselves depending on what their symptomatology is like. So any questions on that specifically? Okay, so getting into the oral contraceptives. Again, these are going to be typically combining combinations of either estrogens plus progestins, or for these patients, for purposes of oral contraception, can I use estrogens by themselves? Could I use progesterone by itself? Yes, potentially you could. And we're going to find there's some drawbacks associated with that, but that's going to be kind of the difference here. So with hormone replacement therapy, there are situations where using estrogen alone or the combination of estrogen plus progesterone. Here, you may find cases where you're using progesterone alone, but more often than not, it'll be the combination of the two put together there. And so you'll find similar sort of cyclic dosing for a lot of different dosage forms that are there. I'm going to post up a PDF today that'll have just a giant list of different types of oral contraceptives that it'll have, just to kind of show you just how many different varieties there are and different sort of strategies you may employ while picking a different product. So when I say things like monophasic, what does that mean? They're going to get just one basically phase of dose, and they're going to get the same constant dosage of estrogen and progesterone all the way through their menstrual cycle. Okay. Now again, for these products, there's typically always going to be the last 7 days is going to be placebo pills in order to have that withdrawal period, right? Because you still want these patients to have their normal cycle. Again, we'll talk about things like scheduling and things like that in a little bit later on. Biphasic is typically going to have at least one change in dosage partway through the month. So you may either have change of, say, dosage of the estrogen or the progesterone. At least one change happens there. And then for triphasic, you're going to find there's two changes that occur. Typically, you have one dosage at week 1, you take a different dosage at week 2, and then week 3 is another dosage change. Okay. And again, these are already factored into the pills themselves. How do these normally come? Yeah, they come like in a punch card pack, basically, where basically you don't even have to think about it. You just have to prescribe the product, and they've kind of already taken it. The patient doesn't have to figure out which one they're taking from day to day. They just have to follow along on the calendar and just take it as they should, right? And then, as I mentioned, there could be continuous progestin-only therapy, but we'll see some drawbacks associated with that. So, as I mentioned, when using these for purposes of contraception or for basically we're trying to inhibit ovulation is ultimately what we're trying to do. We're going to give super therapeutic concentrations of estrogens in order to help shut down that HPA axis to help prevent release of things like GnRH and release of LH and FSH. That way we're supplying all the estrogen and progesterone. The ovaries don't actually have to do anything themselves. So when we did this for male patients, we were giving testosterone. What happened to the main production site of testosterone? Testes. They atrophied, right? And you can actually kind of see the same thing here. The ovaries can actually atrophy to some degree as a result of that because they're not producing their own estrogen and progesterone anymore, right? They shouldn't have that sort of follicular development that occurs there. But we'll still see development of endometrial tissue as a result of these hormones, and that will still cause a normal withdrawal period, withdrawal bleeding, because the tissue is still there, still being sloughed off because it's not needed. You will find other things that these hormones will do will also make it sort of inhospitable for implantation and actual conception to occur. So for instance, you can see things like changes in cervical mucus. You may find decreased motility and secretion from the uterine tubes, different things to make it more difficult for, say, a sperm that actually made it in to actually get to the site of action and actually get infused with one of those eggs there. So overall, a decreasing likelihood of implantation and conception, as I mentioned. You will find the progestins are going to be much more sort of dodgy in terms of how effective it's going to be to actually inhibit ovulation. So you'll typically find that failure rates, and failure rates is an important thing to talk about here, tends to be higher for progestin-only products than it would be for, say, a combination of the two together. Okay, are any of these going to have 100% efficacy? No, right? And that's even with perfect use. Meaning they don't miss any doses, they take the same dose every single day. There is still some risk for pregnancy to occur, but you're going to find it's going to be higher typically with progestins. I'll show you some numbers of that in a little bit. So in terms of physiologic effects, by providing these super therapeutic concentrations, you're going to get these depressed ovarian function, as I mentioned. They do get smaller during therapy because, again, just like the adrenal glands get smaller when you're applying glucocorticoids systemically, the same thing happens to the testes with androgens. Same thing happens here, right? You'll typically find, though, that patients will return to normal menstrual function patterns once you discontinue it. It may take a little bit of time. So for instance, if you're doing a typical oral contraceptive, you find that about 3/4 of women will actually start to ovulate during that first cycle. So it can come back immediately for a lot of patients, but usually by the third, roughly 97% or so are back to ovulating normally, okay? Some may be amenorrheic for a while though, right? So again, it's dependent on the patients or what other sort of cofactors, comorbid conditions and other factors are going to be coming into that. As mentioned, with the uterus, you'll get more sort of, you get some hypertrophy there. You may have some of this like polyp formation that occurs, and overall you get kind of thicker, less copious mucus, and that makes it again more inhospitable to a sperm to actually go and implant an egg. Typically, you see breast enlargement. This can also suppress lactation. Why do you think that would be? If the body's trying to get pregnant, then it shouldn't be lactating necessarily to feed another infant, and that's why you're going to find some imbalance there between things like prolactin and estrogen therapy and things like that. So, for instance, if you have high prolactin levels, what usually happens to ovulation? It can actually get suppressed because, again, if your body's in the state where it's like, I'm trying to feed an infant, keep that alive, I don't need to get pregnant right now, and the opposite can happen here as well. So you may see lactation being suppressed by supplying these drugs here. In terms of hematologic effects, we already talked about how you'll have depressed activity of antithrombin 3, you have increases in clotting factor production, and this is specifically with the estrogen component there. The progestins are not really going to see that. Don't really see many liver effects as a result of progesterone. So this leads to a lot of the thromboembolic concerns. In terms of skin manifestations, you may find things like hyperpigmentation that can occur. Typically, this is patients with more dark complexions to begin with, or if they have a lot of exposure to ultraviolet light. Anyone around here might fit that bill? Mm-hmm. You're in Florida? I would say so, right? So you go down to Miami or somewhere. So some of that may be reversible, but it may not be completely. Depends on duration of therapy and things like that. As I mentioned, you may find that androgen production may be upregulated, or androgen activity can be upregulated based on the progestin that they're using, and that can actually worsen acne for these patients. For some patients, though, what does oral contraceptives do to their acne? It can improve it, right? So again, it's also going to be kind of a double-edged sword. Depending on the patient and which ones you're using, you may find improvements or you may find it get worse based on that. And that's, again, where you can sort of change up which progesterone you're using, maybe using something with anti-androgen activity, and it helps to mitigate some of that, and hopefully will help limit things like the acne that can develop there. So what do we use these for? Obviously, contraception is what I've been alluding to kind of most commonly here. You're going to find that the risk of conception when taken according to the directions is extremely small, but it is still somewhat of a risk, right? And so you'll find, and again, like talking about like these weird sort of epidemiologic numbers here, but a combination of agents, so using an estrogen plus a progestin would see with perfect use, or I'm sorry, with normal use, so again, not everyone, nobody's perfect, as it turns out. And so some people are not going to take it like they should. And so you'd see 5 to 12 pregnancies per 100 woman years at risk. What does that mean? So if you followed 100 women for 1 year, or maybe 50 women for 2 years, you'd see a total of about 5 to 12 pregnancies with typical use. So given the fact that they may miss doses, they may mess up the cycle and take the wrong pills or something like that, like you may find some pregnancies there. The funny number though is that if you had perfect use for all those, say 100 women for a year, you'd have 0.5 to 1 pregnancies, which I'd honestly like, what does half a pregnancy look like? Is it just the left side that comes out, the right side? I don't really know, but did you hear about the guy that actually he's in a car accident and the whole left side of his body was torn off? He's all right now. Anyway. So be aware though, you have to also consider things like drug interactions as well. So if we have things that can induce CYP enzymes, for instance, they may actually help to increase metabolism of the estrogens and help to interrupt their ability to suppress that ovulation. So for instance, things like phenytoin could do this, things like carbamazepine could potentially do this. And we talked about things, anything that can interrupt enterohepatic recycling, right? So we talked about antibiotics being a big, or somewhat of a concern for that, but if they had maybe something like a bile acid sequestrant like cholestyramine, that would certainly interrupt that cycle there, and that also would suppress levels, and that could lead to ovulation occurring, okay? So anything dropping levels of the estrogens is going to increase your risk for an accidental pregnancy. Other things we can use this for, right? Not every patient who is on oral contraceptives is going to be sexually active, but we can use it for things like endometriosis. You may find that estrogen alone could be sufficient, but because of the fact these patients still have an intact uterus, you have to include the progesterone in there. You don't want that unchecked growth or hypertrophy of that tissue there. And again, using the smallest dose possible is going to be beneficial here to help just deal with the symptoms, but not increase the risk of some of the other effects like the lipid effects and cardiovascular risk. So in terms of adverse effects you can find for these patients here, so some of the mild ones you're going to run into most commonly include things like mastalgia, which makes sense because you see that breast tenderness and breast enlargement that can occur there. You may find some edema that could be related to the progesterone activity there, or related just to some natural bleed over effect in terms of the mineralic corticoid receptor effects, and breakthrough bleeding can occur. Typically these side effects, a lot of it has to do with either too much estrogen, So in which cases you may be able to drop the dose down to that potentially, or by using progestins that have more androgenic activity. So again, you have sort of your options here. You may say like, okay, well maybe I want to drop down the dose of the estrogen, or maybe you want to switch out the progestin entirely, right? So again, these are different options here. And again, when I post that PDF, you're going to see just all the different varieties, and there's just a million of them that are out there, right? And you're going to be a fool's errand to try to memorize every single one of them. But again, the concepts behind it and understand what the individual drugs themselves are doing is what's important. Headaches, again, as I mentioned, they can make migraines worse for some patients. These may help in some cases there. Again, we do worry about the risk for CVAs, mainly because of the thromboembolic complications there. So one thing to kind of consider. And typically, if you see that there's sort of a correlation between migraines starting up in addition to starting the medication, that may be a pretty good sign that's not going to be good for that particular patient there. Other things that can occur, you may have a failure to have withdrawal bleeding. Why is that concerning? They may think they're pregnant, right? So if they don't have that withdrawal bleeding, they think they missed their period. And so if it's that problematic, the patients can potentially try other agents, right? Maybe something that's going to be more consistent in terms of giving that withdrawal bleeding for those patients there, right? Again, a pregnancy test is real cheap. It depends. If you go to the dollar store, you can actually get them for $1. And that's how we found out about Phoebe. So it's funny, your first one, you're getting all the really good ones, like you're getting like the EPTs and the first responses and everything. Spend so much money on all these pregnancy tests. And all of a sudden for the second one, I'm like, are you pregnant? And she's like, I don't know. I'm like, we should probably get a pregnancy test. $1 later. I say she's the happiest accident that ever happened to me, so. Anyway, she's great. She's a beast though, she's a monster. It's funny because you can tell like she doesn't really have any like frontal cortex developed yet. She's like just pure id, so if like she wants to do something, she's just gonna do it versus, you know, the 3, almost 4-year-old like has some executive function there, but it's just interesting to see the difference. Other adverse effects you're going to run into, so you can see some breakthrough bleeding. A lot of this may be dependent on the product that you're using. So for instance, if it's progestin only, you typically do find a lot more breakthrough bleeding with them, about 1/4 of patients, versus by using the combination there. So that's one thing to know. And even as well with low dose options, if you're trying to use really low dose estrogens, that's also going to increase your risk for that breakthrough bleeding, mainly by the fact that you're again just not getting full suppression of the whole system there. You may find that for some patients, you may want to limit, say, overall exposure to hormones by using a biphasic or triphasic product. They can help to decrease this breakthrough bleeding depending on which part of the cycle that it occurs in, whether say earlier or later in the cycle, while still getting, say, not increasing the total overall hormonal content. So as they say, for instance, get more breakthrough bleeding towards the, say, 3rd week or so by using a triphasic product that kind of gradually ramps up the estrogen content, that may help to prevent that breakthrough bleeding while not having them take that same high dose throughout the entire cycle. So a lot of it's just dependent on the patient and what your conversation is, what's kind of what they agree to. In terms of weight gain, you're going to typically see this more often with more androgen-like progestins, mainly because, again, they have more anabolic sort of effects there. Also, mineralocorticoid effects can also lead to some weight gain due to fluid retention. And so you may either have them shift to, say, a progestin that has less androgenic effects, or you can get around it with diet potentially, maybe, you know, helping decrease sodium intake, you know, more exercise, things like that. As I mentioned, the hyperpigmentation that can occur here, typically this increases with time and actually can be exacerbated by patients who have like vitamin B deficiencies, which is kind of interesting. Most of the time it's going to be reversible, but it tends to be a little bit slow. So again, if some of the patients are noticing, it's better to kind of get in front of it and maybe discontinue therapy earlier than later. But this occurs more often in patients already have a kind of a dark complexion to begin with. And then I mentioned with the acne there, more seen with androgen-like progestins. You can try switching the products there, and that does help out with that. Larger doses of estrogen typically has sort of an inhibitory effect on acne, so you kind of play around with that and see what product works best for your patient. The hirsutism tends to be aggravated by more androgenic progestins, like we mentioned, so it kind of makes good sense to maybe switch to one that has less androgenic activity if that's going to be a concern there. Other things you can see include sort of things like urethral dilation, right? So you can actually end up seeing similar effects to what you see in pregnancy, because again, what happens to hormone levels in pregnancy? They're quite elevated, so you kind of get similar effects there. And so bacteriuria may be more frequent for those patients. So if they have a history of recurrent UTIs, that could be a concern, something you want to think about for those patients there. Amenorrhea can happen, especially if patients have maybe menstrual irregularities prior to taking the drugs. So it's one thing at least warn the patients about. And again, a lot of these patients end up having things like prolactinomas that are kind of exacerbating this. So those are things you also want to kind of rule out when you're utilizing this therapy here. So the severe effects we worry about include the venous thromboembolism, obviously. So you find that when patients are on low-dose oral contraceptives, their risk is about 3-fold higher than without it. So we know the risk is there, and that's why it's important to counsel your patients about that risk, let them know the warning signs of a VTE, especially things like PEs that we're really worried about. Typically, that risk is going to go up when they first start therapy, and it's going to remain constant while they're on it. And then what do you think about the risk when they come off of the therapy? Goes back down to the normal baseline level for them. So again, if they have already increased risk due to their medical history, and that's obviously going to be exacerbated by that, right? So those may be patients that maybe an estrogen-based product is not going to be good for them if they already have that history to begin with. And again, it's not going to be due to progesterone, so if you wanted to switch them to a progesterone-only product, that's perfectly reasonable for those patients. And again, you worry about things like myocardial infarction, especially if they have other conditions that will help to predispose them to that, things like diabetes, hypertension, etc. Obviously, smoking is going to be another really big risk factor, and that also worsens the risk for VTE, so definitely counsel them to stop smoking if possible. Again, what do you think about patients that are, say, like vaping? Is that still a risk? Yeah, a lot of it has to do with the actual nicotine content itself, so I would certainly still recommend anyone who's having any kind of nicotine intake, they are going to be at risk there. You may see more atherogenesis that can occur here, actually even some coronary arterial spasm, which can limit oxygen flow. So again, these are just risks you can see with this potentially. And more androgenic progestins also lower your HDL, which we know to be protective. CVAs, we certainly know that risk is there. So really any of these sort of thromboembolic sort of complications are going to be an increased risk here. In terms of gastrointestinal effects, certainly cholestatic jaundice can occur occasionally. A lot of that's related, especially with the oral agents. This may be mitigated by using, say, like a transdermal product potentially. Mostly seen during the first 3 cycles or so, and so you're going to kind of know about this early if a patient's going to be at risk for that. And then when you discontinue it, things like jaundice and pruritus will kind of resolve on their own. For some patients, their depression can be worsened. This is not common, but as I mentioned, for some patients, their mood improves when on contraceptives. Their mood may worsen depending on which ones they're on, which progesterone they're on, which dose they're on, etc. So just be aware of that. If they have a history of depression, it could be worsened, right? And then cancer risk is another thing to consider here as well. Basically, we can see an overall reduced risk of endometrial and ovarian cancer. Why do you think that is? Typically related to the progesterone that we're including with that, which is good because it helps to kind of provide a stop to the hyperplasia that occurs due to the estrogen. You may find that overall lifetime risk of breast cancer tends to be unaffected while they're on it. Again, though, if they have a high-risk history, that is something you certainly want to be concerned about. And we do tend to find that patients with cervical cancer or with HPV have a higher cervical cancer risk. So again, not like a slam dunk in terms of causing cancer, but there could be some risk depending on the patient. Okay, so just to give you some comparisons here between the different progestins that you may commonly employ in a lot of these oral contraceptives, you kind of look at their different generations here in terms of their effects, either having estrogenic effects, or more importantly, both our progesterone and then androgenic effects, right? So again, if you're using something in this kind of first generation category here, you're going to see a lot more of those androgenic effects that we already talked about. So things like you're lowering HDL, the acne, hirsutism, things like that are going to be more predominant, especially with levonorgestrel. But you tend to find that a lot of products still contain these because for some patients, it's not really that big of a concern and they do well with it, right? So you'll still see these used a lot. They're fairly cheap, they're old, they've been around for a long time, right? Typically, this is going to get better, especially with drospirenol. You tend to find this has very little to no androgenic effect, which is beneficial. This one is going to be anti-mineralocorticoid as well. So again, I'm seeing this one becoming quite popular with a lot of patients. They do like the effects of this drug because one, it helps out a little bit with weight because you're losing a little bit of extra water. I don't really get any of those androgenic effects. So anyone know of any products that contain drospirenol? If you hear like Yaz or Yasmin, those are kind of like common ones there. So I'll show you a list of that later on. So it's good to know what your contraindications are for hormonal therapy for these patients here. So again, if they have any really increased risk for things like cardiovascular disease, cerebrovascular disorders, anything like that, you want to consider using, especially not an estrogen-based product here. If they have any cause for vaginal bleeding that's unknown, got to rule out the scary stuff like cancer to make sure you're not going to be exacerbating that by giving them extra hormones, right? Heart failure, why do we say heart failure here? depending on the progesterone, you can see some fluid retention there. The estrogen can have some of that effect as well, so that would be one thing to be cautious of. Does that mean that they can't get it? No, you just want to be cautious and make sure they're getting their weights done daily, make sure their fluid intake is being kept in check, salt intake, etc. Why do you think we wouldn't want to use it in adolescents who haven't undergone epiphyseal closure? Because we said estrogens, which will normally peak up during puberty, will close those. So it may lead to decreased stature. So that's a concern for those types of patients. So you're doing it too early, it may lead to growth stunting potentially, right? So that's why, like, when you see, because like who typically goes into puberty first, like boys or girls? Typically girls, right? So you always like think about like being in elementary or middle school, like girls like shoot up in height all of a sudden. They hit that peak first, but the estrogen then closes those plates there, and then when the guys hit puberty, then obviously they end up typically being taller overall, and that's why you kind of end up seeing that. So again, that's the concern here, is if you give it too early, then you end up closing those, and maybe they don't achieve their full height potentially. If there aren't any hepatic enzyme inducers, why am I concerned about this? It'll decrease the efficacy of the estrogens because the levels will be lower, and thus ovulation can occur. So that's a concern with that. Antibacterials we already talked about. Again, am I going to say that every patient who takes oral contraceptives plus an antibiotic is going to get pregnant? No, that's silly. But is it wise to say maybe use some backup protection? Is there any risk with that? Typically no, right? So that is something you can say, hey, while you're on the antibiotics, maybe consider using some backup protection. You won't find any clinical evidence that says absolutely the risk is increased, but it's a theoretical sort of thing there. And obviously, if they are pregnant, you don't want to give them any extra hormones because that may affect the developing fetus. So it can allow the natural cycle for that pregnant patient to kind of dictate those hormones there. But again, could they be pregnant and still taking an oral contraceptive, not know they're pregnant? Right, so that is something you want to discontinue as soon as you get that positive pregnancy test. So, as I mentioned, you can use progestin-only based products here. This is better for patients to have estrogen contraindications, right? Maybe they have a high-risk history of breast cancer that's estrogen sensitive. Maybe they have a VTE risk. You'll find it's not going to be nearly as effective. There's a lot more breakthrough bleeding that can occur there. You may find that for some patients, the dysmenorrhea will decrease with time, or the abnormal bleeding will decrease with time, but amenorrhea is common as well. And again, you may be concerned that you missed the period, maybe pregnant, so that's a concern for some of those patients there. The other big thing to consider is going to be that delayed return to ovulation. So again, if you were, say, for instance, looking to get pregnant at a certain time of your life, this may help to prevent that. It may lead to delayed pregnancies. So say, for instance, you're like, I don't know, say in a 27-month-long program where you say, I definitely do not want to get pregnant during this time, but right afterwards, it's go time, right? A progestin-only product may inhibit that, may lead to a longer delay before that patient does get pregnant at that time there. So little things to consider, right? If they're on a combination typical oral contraceptive, that the delay is much shorter. And a lot of patients do start ovulating pretty much right with the first cycle. So we can also consider use of these products for postcoital contraception, right? So this is kind of like your plan B that you talk about, the morning after pills. The biggest thing to know with these is that timing is going to be of the essence, right? So is this something a patient maybe has a high risk sexual encounter, they have unprotected sex, and they are concerned about getting pregnant? Like, yeah, like the next couple weeks or so, maybe go get a plan B. No, typically within like 72 hours, you find these are going to be most effective, right? It will help to prevent that implantation, the actual conception from occurring there. Typically, these can either be a combination of estrogens or progestin only, or there may be a combination of the two here. So for instance, like your typical Plan B, which you can get over the counter from the pharmacy, is going to be just levonorgestrel, which is just a progesterone, as a 1.5 milligram dose. Much higher is a single one-time dose to try and make sure that implantation does not occur, right? The other big thing to note, though, is that there's a lot of nausea and vomiting associated with this, right? You'll find that you're giving really big doses right up front. So maybe co-prescribing something like an antiemetic may be useful. But typically, if they throw it up within an hour, they need to retake it, right? Then you get another dosage form. If it's beyond an hour, typically you're kind of safe in assuming that the drug has passed through the pylorus into the small intestine. They should be good at that point, right? Should be past the stomach, should be okay. There are different ones that are out there, though. Plan B is nice because it's just a one-step kind of thing there, but again, you may see more nausea and vomiting associated with that. So sometimes they'll break it out into a few different steps, a few different dosages to make that occur there. So just one thing to note. We'll talk about IUDs a little bit later on, but you can also use things like copper IUDs. IUDs just stands for what? Intrauterine device, right? So the, like copper IUDs can also be used for postcoital contraception. We'll talk about those a little bit later on. Other benefits of using these oral contraceptive products include things like reduced risk of endometrial cancer, ovarian cysts, things like that. Why do you think it would help out with iron deficiency? If they reduce overall bleeding, then they're holding on to more hemoglobin, unless you may not need as much iron in order to keep around, right? And frequently, what's included in some of these oral contraceptive products? They'll include iron. Even in the placebo pills, there may be still some iron in there because, especially patients with heavy bleeding, it's important to make sure their iron stores are being kept up. Rheumatoid arthritis is interestingly has a reduced risk there. I don't know the mechanism for that, but it's interesting to know anyway. And then, as I mentioned, endometriosis, acne, hirsutism, all these can be beneficial, may benefit, or in some cases may be worsened depending on the product you're using for those patients. So typically, if you're starting a patient on oral contraception, you want to start with a combination pill unless they have an obvious contraindication. So they have abnormal uterine bleeding and you're not sure why they're having that. They have, factor disorder and they're at risk for clots. Obviously, combination pill is not going to be great. But start off with a combination for most patients that don't have any contraindications. And then typically you're going to use the lowest effective estrogen content you can. So you're using about 30 to 50 micrograms, which again looks like it's quite low as a dose as compared to the hormone replacement therapies we're talking about. Like, Premarin, you may be using like 0.6 milligrams. And 0.6 milligrams is how many micrograms? 600, right? So 0.6 milligrams is 600 micrograms. It looks like it's a lot higher dose here, but really we're using more potent estrogens, and so typically, especially the ethinyl estradiol, what we're using most commonly, these are quite potent, and so even though it's only 30 to 50 micrograms, it's still super therapeutic over what the patients would normally be producing, and will shut down that system there, right? Want to make sure they find an acceptable level of side effects and talk about with them what to expect, what is concerning, keep track of these things, so that way they can come back and talk to you to say, hey, is this a product worth continuing or not? And typically, you give them a 3-month supply. Why would you give them that much? Kind of see how they're going to respond to it, right? You may find that the first cycle may not be indicative of what it's like at the third one. So give them 3 months and see how they're going to respond to it, see how they like it. And if they really just hate it, especially in the first month or two, they can stop it early, but at least you have given them enough time to kind of see how they like it, right? And then you can try switching up if you need to when they come back. So typically we start oral contraceptives on the first Sunday after the onset of menses. Does anyone know why we do it on a Sunday? What is magical about Sundays? It's the Lord's Day. For some. Is that anything to do with it? Probably not, no. Why would we do that? That's what it says on the pack? That's a good one. The pack says it, so I must do it. No, so typically what that does is it helps to prevent withdrawal bleeding on the weekends, right? Most people tend to have their off days on the weekends, and so if I'm going to be miserable, it's just like calling out sick to work. Like when you guys are out there working in the field, you're like, I'd rather be sick at work and be miserable than on my days off, right? I'd rather feel good on my days off. So just like this, if you'd rather not have withdrawal bleeding on the weekends, you can start it any day of the week though. It does not matter if the patients are working every weekend and they don't care. There's nothing magical about that Sunday, right? So that's one thing to note. Post-pregnancy, typically they wait about 3 to 4 weeks or so post-delivery, and then patients can go back on that to prevent maybe secondary pregnancies or help regulate some of their hormonal sort of production, because you can find some pretty rapid decreases there after the pregnancy, and so that can help out with some of those side effects there. And then if they were to have an abortion, again, just start the first Sunday after, and again, put them back on a normal contraceptive cycle there. So, when to recommend using, say, a backup form of contraception, maybe a physical barrier or something like that. Some people feel that you can use it on the initial cycle. Maybe you don't have full suppression just right away. That's kind of controversial. There's no evidence to say you have to. Is it a bad advice to say maybe use some backup protection? Probably not. So I think it's okay to recommend that, but it's not absolutely necessary there. Missed pills, we'll talk more about that specifically in just a little bit, but especially the more low-dose estrogen you're using, or if you're using progestin-only products, the lower the doses you're using, the more that a missed dose will potentially lead to ovulation, right? It will potentially lead to failure of the product. Higher doses, you have a little bit more leeway with. Okay, so just be aware of that. They're having severe diarrhea. Why do you think that would be important? it may be interrupting that enterohepatic recycling because you're just clearing everything out so quickly, and maybe that may drop levels. That's another thing to consider there. And then we talked about the antibiotic risk being theoretical, possible. Again, it's not a bad idea to recommend maybe using some backup protection. So what do we do if a patient misses a pill? You say, that's it, you're done, you can start the whole pack over again? No, there's some things we can do. So if they miss a single pill, especially if it's the same day, they can take it as soon as they remember and they're good to go, right? They can continue on with the normal dosing, no problem, okay? If they miss 2 days, then at that point we say you can take 2 pills for 2 days and that will get you back on track, okay? They may experience some extra nausea, vomiting related to that, but at least it puts them back on the track and they can stay on their normal sort of cycle there, okay? If they miss 3 or more, at that point, levels will probably drop down low enough that you're not really suppressing ovulation anymore. The risk is there. And so I do recommend go ahead and desync the rest of the pack, just throw it out and then restart on Sunday or whatever day is their preferred day to start it, okay? So 1 or 2 days, not a problem. We can get around that. 3 days, go ahead and just start all over again, okay? Yes, ma'am.
And when you say that, you mean in a row, not like on separate occasions within the contraception pill?
Yeah, within the pack. If it's like multiple times in the same pack, then of course your risk would probably go up above that. You know, at that point there would be like talking with the patient like, okay, what's going on? Why are you missing these doses? Is it an issue if you're just forgetting, or, you know, things like that, because there's probably some other compliance issues that I'd probably want to address with that patient at that point. Yeah. If it was like, I went on vacation, I forgot my pills at home, you know, I was out for the weekend, like not a big deal, right? They can just double up for 2 days and they're back on track. It's no problem. So if they have a missed period, say they have a failure to have that withdrawal bleeding there and they have no missed pills, so they were compliant throughout the entire month, they typically, you don't have to go out and run and get the pregnancy test right away. If you saw it maybe at a 2nd month, then you probably consider doing testing at that point, right? So you don't necessarily have to run out there and test yourself. If the patient's really freaked out and worried, what are they going to do anyway? They're going to get the test regardless, right? So again, you can't control human behavior, but you can at least let them know, like, yeah, just go ahead and wait till the 2nd time, because again, you don't know how they're responding to that that pack, especially if it's a new start. By the 2nd, you know, cycle, they may be back to withdrawal bleeding like normal, just depending on the drug they're using. So, so anyone heard of like honeymooning before? What's honeymooning? Yeah, you can reschedule the period. I thought this was black magic when I learned about this, and I was like, that's impossible. You can't do that. Like, it's the moon's controlling this thing, and I mean, like, the moon doesn't go anywhere, so it's like, what? No, you can absolutely reschedule the cycle there. So, and in fact, there are some products that you can administer to these patients where they may only be having, say, 4 withdrawal bleeds, say, in a year, right? Or they may go continuous year and only have 1 withdrawal period there, right? So again, there's nothing magical about having this week off of these hormones. It's just mimicking what the natural cycle would be. So if they did have something coming up, like say for instance, you have an event coming up, a vacation or anything like that, they can just go ahead and continue taking active pills. So say they were coming up on their placebo pills, they can go ahead and just keep, say go to the next pack. Because usually when you're looking at like refills at a pharmacy, within a week or so, they can typically go back and get your next refill done. Or if you get like 3 at a time or something, you may have more available to you. And so you can just continue taking active pills until the event is over, and then you can allow for that placebo period to start and kind of start the whole cycle over again. So that's one thing to consider there, which is beneficial to patients who may have an event coming up. They're not destined to have their period during that time. They can move it around. In terms of stopping pills, you know, there's no real need for rest periods necessarily. Some people may feel like they want to not go with it for a while. They want to kind of give their body a rest, so to speak, but not necessarily. If they have a desired pregnancy, so there's a certain period of time they would like to get pregnant, typically you'll allow for sort of 3 regular cycles prior to conception. Again, by that point, if they're still not conceiving, then you may want to look at other issues related to that. But a lot of patients will start their normal ovulation the first cycle out, right? If they're having breakthrough bleeding, depending on when it's occurring, you may be able to adjust the dose of your drugs to address this. So for instance, say during the first 3 months, generally resolves on its own, right? The body's getting kind of used to having these extra hormones around. It will have some adjustment period, and that's why that first missed withdrawal bleeding may not be that big of a concern as you get used to it through the first 3 months. If it's still present after then you can consider sort of where the bleeding is occurring in the cycle and adjust your doses accordingly. Typically, if it's during the first, say, 2 weeks or so, that may be a result of an estrogen deficiency. And you'll see that more with your, say, bi and triphasic products where they kind of gradually ramp up the estrogen dose. In those cases there, you may go to something that's maybe monophasic that has a higher dose early on, or just use an overall higher estrogen content for the product you're selecting there. If you're having bleeding, say, that 3rd week, that is frequently going to be related to progestin deficiency most often. And so again, by adjusting which progestin you're using or adjusting the dose, that is a way to get around that as well. So just things to consider when the bleeding is occurring. It could be a result of either deficiencies of estrogen or your progestin. Some other miscellaneous products you'll run into, things like Depo-Provera. We've talked about this before. This is just a shot you get every 3 months or so. This one is particularly bad about causing anovulation for a long period of time because, again, the levels are not 0 at the end of that 90 days. You may find that you'll have effects for, say, 4 to 6 weeks even after that, which may be good if you have patients that are maybe hard to get to follow up with you to get their next shot and their compliance issues. But you're going to find that they have very irregular menstrual patterns. Amenorrhea is quite common here, and then they had that really delayed return to ovulation, more so than just with, say, like an oral product they're taking. The levels will drop off much more precipitously with an oral product. Here's some examples of some intrauterine devices that can be put in. So here's an example of levonorgestrel or Mirena. Again, levonorgestrel, is that a progestin or an estrogen? It's just a progestin, right? So this is something that can be applied directly into the uterus. Basically, your OB-GYN doc or whoever would actually directly put this in. Notice it has little strings hanging off from there, so it can be removed at a later date. These will, again, have drug impregnated into the product itself that slowly leaches out over time, and this can last up to 5 years. So again, from a compliance standpoint, it's kind of like that old infomercial, you set it and forget it. You don't have to worry about it, it's there. No one saw that infomercial? No one watches as much TV as I did growing up, I guess, or we've missed our generational divide, I guess. Regardless, though, again, compliance is the nice thing here. You will find also that you just get nice local effects. You will find less risk for things like thromboembolic risk. You have less risk for things like breast cancer and all these different things because, again, you're just getting a little bit of progesterone right there. And again, it's not necessarily that it's suppressing ovulation so much, but it's just making the environment really inhospitable for a sperm to actually come in and implant an egg, okay? Here's an example of the Nuva ring, where it's actually going to be implanted into or put into the vagina. The patient would do this themselves, and basically this is a product where you'd have 3 weeks in and then 1 week out. This is another case where if it fell out early, they can just put it right back in. These are going to be things that, again, will help to mimic that normal cycle by having some withdrawal bleeding, but overall making it such that it's inhospitable for pregnancy to occur there. If the patients have really good insurance here, you can get the Nuva Bling, right? I'm just kidding. I would not. That looks like it would irritate the tissue quite significantly, so I would not use that one. But other products there include things like implantable products here. So again, you have something like Implanon that could be put in every 3 years, for instance. So again, just depends what is preferred by your patient. Here you get more systemic levels of the progesterone, which would lead to some more irregular bleeding, so you don't get that nice local effect, but some more systemic, so it's another thing to consider. That'd be implanted in the office itself. A patient obviously would not be doing that. Here is an example of Paragard, or the copper intrauterine device here. So this is really interesting because it doesn't have any hormones associated with it whatsoever. Basically, it's just kind of slowly leaching off copper ions, and again, that makes the environment very difficult for a sperm to actually come in to transport and actually fertilize an egg itself. So again, overall, no hormones. So if you had someone who had absolute contraindication or said, I don't want anything to do with hormones, this could be a really good option for them. And again, this is also often used as a postcoital contraceptive as well to make sure pregnancy does not occur. If you have like something like a rape victim or something like that, this could be used in some of those cases as well. Again, this has to be implanted by or put in by the provider themselves. This one's also nice because guess what? 10 years you don't have to think about this one, which is really good. Patients, maybe they've had their kids, they don't want to think about getting pregnant again, or they just don't want to have any kids. This is a good product for them potentially. I don't know if there's any cases of copper toxicity. You can get copper toxicity overall if you were to drink certain substances, but I'm not familiar with any that actually occur because of this. But again, it's a very small amount of copper ions here.
I've heard of some incidences where these get actually implanted like incorrectly and cause cancer. Does that have anything?
I don't know about the cancer risk. Typically, you'll have patients that will come back after they're put in because there is a risk for them migrating actually into the abdominal cavity. So that is one concern. They'll actually get kind of into the tissue and kind of just fuse into it and eventually get into the abdominal cavity. So I know that is a risk with any of the intrauterine devices. Cancer, I'm not as familiar with. I'm not sure. Also be a really good question for Professor Lack, since she's going to be teaching that after spring break. So it's another thing to think about asking. So that's going to be it for me today. Let me see if there's any questions. How many slides do I have left? Only 5. I guess I can. Yeah, there are probably a lot of questions. So I'll finish this up. It's fine. I can go over into the next topic. That's no problem. Let me see. Oh my, holy moly, that's a lot of questions. I should have stopped 10 minutes ago. Okay, let's see. Where'd you start? Are all these like actual topical? Am I going to read one of these and like halfway through talk about like get Manchurian candidated into like doing something weird? No. How does thyroid hormone imbalances cause prolonged menstruation? That's a good question. Do you guys know? That I'm not sure about. I have to look it up. Maybe one of you could look it up in the report back, perhaps. That one I'm not sure about. What do the progestinal effects with the first generation cause? That's basically going to be helping out in terms of, one, with the suppression of the HPA axis. So it'll have a stronger effect there, which may, overall, I don't know if there's any efficacy differences between, like, say, something like drospirenone versus like one of the earlier ones there. But those are the main things. You may see some effects on the lipids, but clinically it's not going to be as important as the overall like mineralocorticoid effects and the androgen receptor effects we talked about previously. I talked about this one already. What is the risk for osteoporosis so high with Depo? Well, if you would imagine, are they getting any estrogen effects? Right, so if you think about it, that progesterone is feeding back and inhibiting that HPA axis, so the hypothalamus and the anterior pituitary is being inhibited there. What happens to estrogen production? It's not going to be as high, and that could lead to things like osteoporosis developing in the bones because they have overall less estrogen being there. So that, again, is a risk you want to consider there with your patients, especially if they, depending on what other kind of conditions are going on. So that's something to consider there. I've heard the men form of birth control trial was ended early due to increased risk of suicide. Is this true, and why? I don't know. I've heard different things about different trials being used there. I don't know. Maybe it caused like some severe decrease in testosterone or something. Maybe that affected their mood. I don't know. Let's see, why would progesterone cause the inhibition of the implantation of that egg if it is also used to help maintain the pregnancy? That's a good question. I'm not going to get that far into sort of the physiology. I used to talk much more in depth about that when I taught physio back in the day. So you may have covered some of that with Professor Kaplan. But basically, though, it has to do with the suppression of your LH and your FSH, more so. Like, yeah, you're going to be producing a lot of estrogen progesterone, especially with the placenta, producing a lot of that when the actual pregnancy occurs there, so it helps to maintain that pregnancy. But overall, we're using that progesterone to help prevent that from occurring in the first place. So again, it's helping to shut down LH and FSH, so that way you never get that follicular development, you never really have that the ovulation occur itself. Hopefully that answers the question there. Does the breast enlargement continue after discontinuation of the OCPs? It shouldn't. It should go back down, I would imagine, because if you don't have the estrogen stimulation, then it should go back to sort of pre-hormonal levels, just like most other things will go back down to normal. Things like the testicular atrophy that occurs with androgen supplementation. I mean, that goes away as soon as you stop taking the androgens exogenously. So I would imagine that goes back for most patients. Notice how I always hedge my bets? I say probably and mostly and things like that. So that way I give myself, so I'm not technically wrong. I can say, I said may. I may be late. And say I was going to be late. Always give yourself some wiggle room. If the patient had not had a hysterectomy, is it okay to use Premarin topically? Premarin by itself, that's probably more of a question on a case-by-case basis. I would be cautious with that one. You may still consider using like intravaginal sources, a product there, but again, I would be more cautious and want to talk with like an OB-GYN provider to see if they have any better thoughts on that one. Are there any negative side to effects of honeymooning for long periods of time and not just for a specific occasion? Not necessarily. I mean, there's FDA-approved products. There's ones called like Seasonal and Seasonique that allow for maybe just 4 periods a year. Some of them are just for 1 period a year. So having that constant exposure to estrogen and progestin does not seem like it causes any sort of risk there. And especially if it's a short duration of time, like a week or so, you're probably not going to run into any problems from that standpoint. So it's relatively safe to do. Let's see. What is the number, or what is the mechanism of increased number of vaginal infections with OCPs, and why are they more difficult to treat? It may be related to kind of the local environment being a little bit more hospitable to changes in pH and things like the mucus production that may get more hospitable to bacteria to grow. It may make it more difficult for the, especially if you have like recurrent infections, resistance is an issue. So I imagine that can lead to a little bit being more difficult to treat in those cases there. So, did I answer all the questions? There's another, which one? Okay. What would you use intravaginally topically if a patient had not had a hysterectomy? Potentially, and again, it's all about hedging your risk, right? So, for instance, topically there were combination products. You could use an estrogen and a progesterone together. That would be the safest. I would imagine intravaginal products similarly would be the safest. So you wouldn't necessarily want to use an unopposed estrogen because that would somewhat increase their risk. Again, by using something intravaginally, the risk is again lower because again you're just getting that kind of local action as opposed to like a systemically applied product there. So again, all about hedging your risk in terms of what the patient's, saying kind of getting what acceptable level of risk, I should say, is for that patient there. Okay. That's a lot of questions. I think that's the most we've ever had in a class. So you guys are really interested in this topic, which would be great because then Professor Lack will come in and say, no, that was all wrong. Here's what you really need to know about this stuff. Okay, if nothing else, then any questions? I will let you guys go.